Hey, good morning. We are back. As always on Friday, we are here with Dr. William Whaley, Dr. Ray Tidman, and this segment is proudly brought to you by Georgia Cancer Specialists.
Probably, yeah.
Proudly.
Oh, yeah. I thought you said
Proudly.
probably. Oh, proudly?
Proudly.
All right, you got
Affiliated with Northside Hospital. How are you guys this morning?
Great. Great. I'm wearing a jacket.
Yeah, a little chilly this morning.
Yeah, that's why we're in here.
It is sunny though. We've got the shade. We've got the shades pulled, and
You don't really know it, but we have a truck that we move. Sometimes you hear us say move the truck to
That's
block
right.
out the sun there.
That's right.
That's an expensive sunshade.
That's expensive sunshine.
Whoever has a CDL gets to move the truck that morning. Anyway,
All right.
good to have you here.
That's
What you
good.
got for us this morning?
All right. Well, we got one brief question we were asked.
Okay.
Where did that question go? Right here. Let's see. This came
Right
in
in front of you.
This came in from This
Oh,
came
that's
in
you.
from Brian a few
Okay.
minutes ago. I have Achilles. This is not a cancer question, Northside. I'm trying to respond to the owner here and his friend. I have Achilles tendonitis. I want to try to expedite getting rid of it. Is it best to stay completely off it or use it a little bit? Any other advice about how to treat it? Now that question tells me that the guy's probably athletic since he seems to be impatient. And I would say that did you make the diagnosis yourself or did you go to your PCP and he says you've got Achilles tendonitis?
Primary care physician.
Primary care physician, because if he'd gotten as far as an orthopedist or a sports medicine guy or something, they would have given him this little list right here, which says, how is Achilles, this comes right out of Up to Date. So this was printed in made up in the last 2 or 3 days by the American Academy of Sports Medicine.
Cutting edge here, folks. Cutting edge.
Cutting edge. Okay, Achilles tendonitis usually gets better on its own, but it takes months to heal completely. Rest the Achilles tendon and avoid any activities that cause pain. Well, not a primary care doctor in the world that doesn't tell you if your knee hurts, your hip hurts, when you do that, well, don't do that. I mean, that's sort of simple, right? And then rice, right? So it says ice the area. If your pain gets worse after activity, put a cold gel pack on it for an hour or two, up to 6 hours, 4 times a day. Wrap your ankle with elastic bandage. Can help your tendon from moving too much. Take acetaminophen for pain relief, or ibuprofen or naproxen to help decrease the inflammation. And then, when the pain's gone, you've got to exercise your calf muscles, make them more flexible. Your physical therapist or your doctor will show you what exercises to do. And then if you don't get better, they end up putting a brace on it or have an operation. But what that tells you at the top is you got to go see somebody. And at the bottom, you got a physical therapist or doctor telling you what to do. And the question was asked as if the guy was doing self-diagnosis. Would you agree, Ray?
Yeah. Yeah,
So,
absolutely.
yeah, okay. So my first advice is go see somebody, because if it's torn versus just inflamed, you got another thing going. All right, let's get back to cancer. Okay, BKP, we did what you told you, and whoever it was that put pressure on you, we answered the question. All right. My husband is 70 years old and in his 3rd year of Keytruda treatment for bladder cancer, and doing very well with a recent negative PET CT. Okay, that tells us that the patient's got bladder cancer that has recurred, probably, in the lung or the pelvis, and is not, so he has stage 4 disease. He's 3 years into treatment, negative. The fatality rate with metastatic disease is usually 6 months to a year. This guy's doing great on the drug Keytruda. Now, that's the Jimmy Carter drug. Remember, he got it for brain, lung, and liver mets, and 4 years out now, and still hammering nails and creating havoc.
And he's real small.
Yeah. He's on cortisone.
Diminutive.
All right, he's on cortisone for low levels caused by the Keytruda. Now, so that tells you one of the side effects of Keytruda is that it can lower the function of the pituitary and various endocrine organs, and they're carefully monitored. The guy picked it up and they put him on Keytruda. His PCP saw the oncologist's labs. Now that means the oncologist does like I do and sends a note in the labs to the PCP every time, so he'll be in the loop. Plus, if the blood sugar is high, we're going to want the PCP to get the daggum blood sugar down, right? All right. Called my husband to come into the office as an emergency and ordered an MRI of the brain for a possible brain tumor and an endocrinologist consult. The oncologist said cancel them because they're good reasons for the abnormal labs. What do you think? All right, Dr. Tidman.
Well, there's a lack of collaboration there, for
It's
sure.
right. Now that's
Between the primary care physician and the
Primary care
oncologist.
and the oncologist, who is oncologist at this point, is majorly in control of this patient's success and workup. The oncologist undoubtedly is doing routine labs, doing routine X-rays, doing all that kind of stuff. So that may already be in the chart. And I'd be calling the oncologist and say, "Where are you with this workup?"
Yeah. Well, what I generally do is I tell the patient, I'm in charge. I don't want you going to the barber shop that I don't know about it. If I'm treating somebody with a drug like Keytruda,
Yeah.
now I'm going to enfranchise the PCP to everything that we're doing, and I'm going to call him in quick at home at night. Say, hey, this guy's blood sugar's going up because Keytruda can do that too. I don't get into blood sugar business.
Can we just, for simplification purposes,
Yeah.
can we take a couple steps back for my edification? The patient has probably already gone through a series of chemotherapy treatments.
Yes, way back 3 years ago.
Yeah, it's been
So-
on it for some time now.
3 years ago.
So they changed. So then when that was over, they changed from chemotherapy to immunotherapy.
Yes, sir. And
So
that's-
Keytruda is an orally taken
No,
drug.
It's an IV infusion.
It's an IV infusion
Yeah,
drug.
but it's
still immunotherapy.
Immunotherapy. That's
Okay.
right. Okay, and chemotherapy, as you remember, has a sort of a sunset position. You can't give that stuff forever. Keytruda you can give for a long time. Okay, pop that next thing up there. So what the primary care physician was worried about was the guy's pituitary gland was kaput. Now, if this was just a guy who came into the office with weakness and Ray saw him and had all these things, he'd be exactly the right place to go. The only missed place is the guy's taking a drug that does that to him. You got that up there, hypopituitarism in adults? All right, pull that thing down. This is going to be kind of quick, but the pituitary is about the size of a grape, and it sits right smack in the middle of the brain if you just go right there at the base of the brain. And when he told the patient that he wanted to do a MRI to look for a tumor in the brain, he really wasn't talking about cancer. He was talking about a functional adenoma that might have some size to it that would be misfiring, so to speak. So you got that picture up there? This little thing is bigger, not a whole lot bigger than a pea, right, Ray?
Right.
And it puts out all these hormones, ACTH and TSH. You don't need to know all of them, but thyroid stimulating hormone, adrenal stimulating hormone, testicle and
it the
ovary.
master gland.
Master gland, yeah. All right, so pull that next one up there. Here's what Dr. Tidman would do if he had this patient. He's got this big old thing here, and he would go looking down all these little, we have to have one of these every time we answer a question, right?
Our flow sheets.
Yeah, flow sheet. He'd get going down that big old long flow sheet, and he would decide whether this was some other thing mashing on the pituitary that made it not work, or whether this was end organ failure. All right, pull up the next one, and we'll look at this just for a second. So the adrenal, that's cortisone, that's Jack Kennedy's disease. He had
Right.
Addison's disease.
Right.
So this is iatrogenic Addison's disease. That is the most common I see in Keytruda, and we have maybe 1 out of every 10 or 1 out of every 20 patients on Keytruda on a steroid for that. Then the second is thyroid, and many of them get a little bit messed up thyroid tests, but they're not clinically low in thyroid. So every abnormal test is not a case. Now, I think there's a family doc in an orange shirt that keeps telling you that every positive COVID test is not a disease. Is that what Dr.
That's
Tidman
right.
said?
Constantly.
All right. So every abnormal thyroid test does not mean that you have hypo or hyperthyroidism. But that's very common, and that was one of the things that the PC picked up on. Now, the last one, you pull that down now. The last one was low testosterone. Now, the low testosterone can also be from the Keytruda, but that's kind of rare. This guy had bladder cancer. Where's the bladder? It's right down there next to the prostate and to the gonads, the testicles. He probably had radiotherapy or a big surgical procedure which would have interrupted the blood supply, and his testosterone levels probably been low for the last 4 years. So you gotta kind of collaborate. So that's all. That's the end of the day. The guy's got good reasons for it. The oncologist was already on top of it. And I would say, listen to the oncologist. Don't get an MRI. It's a $5,000 test you don't know, and your husband doesn't have a brain tumor.
I may mention the flow sheets because we bring those up almost every week. Sometimes patients will come in and they'll want a test, and you have to talk them down from the test. One of the utilities of a flow sheet is that if you've got a complex diagnostic workup, rather than getting a shotgun out and ordering everything and then see where it all falls out, you can save some money by saying, okay, well, we do these 2 tests first, and then it sends over to this side or this side, and we work down that flow sheet. So we don't have to do a whole bunch of tests over here once we've excluded that whole range of possibilities. So the flow sheet helps the physician rapidly narrow down the diagnosis without overspending on testing.
Yeah. And that's done on a routine basis?
And particularly in complex situations like oncology, where you've got so many possibilities, and you want to not blow the budget, but B, you do want to get to the bottom of it as quickly as possible.
And I hate to say it, but you see these ads on TV, and Keytruda is advertised on TV.
Yeah. Keytruda, as I understand it, it's got far-reaching.
Oh yeah, we use it in lung cancer, all kinds of cancer. But the problem is they advertise it on television. I mean, it's a great drug. I love it and use it every day. But I think when you have a TV ad that's direct to consumer, you get in trouble. And then the second thing is, the guy's wife probably got on the internet. And 2 places they ought not go is get on the internet, and the other one is worry about the TV program. I mean, I think when you got this kind of question, you go to your primary care doc and you say, I saw this on TV or I saw this on the internet. Not please give me this test or that drug, and what do you think? I mean, that's basically it. That you can't treat yourself like the Achilles tendon. I mean, the guy may have Achilles tendonitis. He may have something else. He can have thrombophlebitis, have the same symptoms, and think he's got Achilles tendonitis, which is why I say go see somebody.
I'm not trying to get you all off track, but
Yeah,
let me
you
ask.
are.
No, seriously. Let me ask you the question.
Right.
You both bring up an interesting point, and you say they see something on TV. Is this a regular occurrence in practice?
Oh yeah. Oh,
yeah, that's what I figured. I mean, it was kind of a loaded question. Now, in days past, what we referred to as an ethical drug, something that had to be prescribed, was not allowed to be prescribed.
No, it was not. Advertising was taboo when I was a student.
That's right. It was taboo, not too far in the past.
Not too long ago, yeah.
So has that made your job more difficult? That you're being second guessed by the patient?
I don't know if it's second guessing, but it does bring patients in with preconceived notions of what's possible. I'm in general for patients being informed.
Okay.
And if the advertising is ethical and informative,
well, they've got to be in compliance on the advertising. So you assume that it's going to be,
Yeah. Now that's why you got that guy talking so fast at the end.
Yeah, trying to get in all that.
Get all the lawyers speak.
That's right.
Anyway,
I mean, you both burst out laughing when I said that. So that is a regular occurrence, huh?
I am not against. I'm sure that was a Supreme Court decision that you have the right to free speech or something, and I am not against the idea of advertising. I am against the idea of taking a drug that's $14,000 a month and trying to convince the public that they need to go in and ask for the drug.
And it's a very, very rare drug. I mean,
you don't use it.
It's not like Viagra.
Yeah, this ain't penicillin for a strep throat, if you know what I mean.
Now, let me use the Viagra as a good other side of it. Okay, so for many men who are very embarrassed or whatever to talk about certain subjects, the fact that Viagra is out there in such a common name and a word that they're more willing to come in and ask about the blue pill.
And that's very good. There you go. That was a good point, right? That was a good point. All right, the second question. This is a little complicated, and Ray's going to throw this at us in a different fashion now.
Yeah, I'm going to be the medical student.
Okay, the question. You got the question?
Yeah, I got it. I'm going to do it.
Okay,
Let's try. I'll just set this up.
Tell them a little bit about how medical students and how this works. Ray's been up all night, and this patient came in through the ER at 10 at night, and he's been checking his blood, sticking his finger, and checking his urine, and taking a history. And he's going to present this case and ask what to do. Go ahead, Ray.
So, a third-year medical student, is up all night doing rounds, as is the intern. Now, the call comes up from the emergency room, and the intern, of course, has got the beeper, so he takes the call. And he says, Dr. Tidman, there's another case in the ER needs to be worked up. And, if I get up and go do it, I'm making less per hour. But if you get up and go take care of it, you're getting more for your money. So, of course, I go down there and work this case.
Now, he's paying the
I'm paying tuition.
He's a medical student.
Right.
And the intern,
he said cynically.
And the intern's making I got $100 a month for 126 hours a week when I was an intern.
I was making less than the minimum wage. I was an county employee in a very progressive state, I'm not going to name it, making less than the minimum wage while they were running around touting about how good they were to the citizens. Anyway, nonetheless. I've been up and worked up several cases. In the morning, we have rounds where the students almost always present the cases that they've worked up, and the attending comes in, nice, clean, brisk white coat.
6:30 in the morning,
but he had a full night's sleep, or she.
Yeah, he's well rested.
Yeah, exactly.
We're like, so anyway, this case is Dr. Whaley. I have I'm going to put some ages and race on it because it was missing here. But we have a 70-year-old lady who's come in with a history of rectal cancer, and she's had a round of chemotherapy for about 5 months, and they found a couple spots on her liver, and sure enough, the rectal mass is still there, and they're wanting to do some surgery on this lady. What do you recommend?
All right. Well, the first question I'm going to ask me is, how well did she respond to the chemotherapy? Did the liver spots get bigger or smaller, and did the rectal lesion respond or not respond?
Well, we assume, because this lady's a very poor historian, that they've not responded very well at all. But I'd have to go call that fella up, and it's not 9 o'clock yet, so I haven't reached him.
All right, so the actual question says the rectal mass is gone. So the patient did respond. So the patient did respond, and the actual question says the 2 liver spots are almost gone. So historically, metastatic colorectal cancer to the liver, before modern therapy like this, you would say 6 months to a year of survival. Now, it's clear from the way this patient was treated that the goal at the outset was, can we take this patient that has disease in 2 locations and convert them to a curable stage? Interestingly, we had the same question 3 or 4 weeks ago about a prostate cancer with a single metastasis they were going to do stereotactic radiotherapy on. And we indicate if you can get that single metastasis and you get all over the disease, then you can dramatically improve survival and increase the cure rate. So let's get that first slide up there. First of all, what in the liver would be resectable? So this first thing here just shows you what the liver looks like. I want to say, for the sake of the audience, that liver is about the size of a small loaf of pumpernickel bread and pretty close to the same color. You can pull that one down there, Emily.
When you say resectable, let's tell them that's cutting out a piece.
Cut out a piece.
And put the other 2 pieces
let's
together.
Go back to liver transplant.
Right.
As you're aware, there are family or directed liver transplants where the donor gives up part of the liver. You can take up to 6/7 of a liver and the other 1/7 will do like a salamander's tail and regrow. They usually don't take quite that much, and the liver is divided into various segments, kind of like a orange where you can peel it apart. But so you have to keep part of the blood supply and the lobe things all intact and uninvolved by the cancer to be able to get a couple of. But if you got 5 lobes of the liver and you got 2 metastases, you clearly got a lot of liver that's not involved. All right, so put that next one up. There's always got to be one of these. We just had another one.
Flow chart.
Flow chart, and we got to have it every time. So this talks about colorectal liver-only metastasis. And so you then take this patient and you take all of the data and you go to a multimodality tumor conference. That means you got a radiation therapist. You can pull that down so we don't confuse everybody. But you've got an invasive radiologist, the kind of guy that goes in and then infarcts the liver by putting coils in there and then depriving that portion of the liver of blood. You've got a surgeon that can look at it and say, yeah, and then you can do that then in different lobes of the liver, and you can do it at every part of the liver. And then you've got a surgeon that says, look, I can resect this and leave a lot of good liver. It'll be better off if you can get it shrunk down with some chemotherapy. Now, the rectal cancer we still haven't talked about yet. So, but at the original conference, they would say, okay, we think this liver is going to be resectable and curable. Otherwise, what they would do is probably radiate the primary cancer and treat them with chemotherapy and not try to operate on either one. All right, so the criteria, this is called, you have to put the next one in, limited indications and extended indications. 3 or less liver metastasis is better than having 3 or 4 or more. And then the localization in one side of the liver only, so that you're leaving a part, is better than having it on both sides of the liver. The fact that there's no signs of disease anywhere outside the liver, and that you can get yourself a margin that's at least 10 millimeters or a centimeter and leave healthy liver around it. You can pull that down, okay? Now we got to have one of these every time we talk about it, right? So this is a group of about 150 patients, those that could be resected and those that could not be resected, treated identically. And the top line is obviously the survival of the people who got resected versus the survival of the ones who didn't. And if you look real carefully, that thing flattens out at about 5 years and starts extending flat, and that's 30% survivals out here at 8 years. When you can't get it out, just about everybody's dead by the 3rd year. So there's a huge improvement in that approach to get the liver. Now show that next question, since we're talking about rectal cancer. We're talking about cancer that's way down here at the bottom. And there's a little bit of difference in the outcome of cancer, whether in the right colon or but rectal cancer is pretty clear. That thing's stuck down to stuff around it. Now pull that out, leave everything down. And generally we treat the rectal cancer. In fact, we had one of these about 4 weeks ago by giving chemo radiation therapy, then removing the cancer, and with or without a bag, or whether you can hang it back up again. Show that next one. And then at the end of the day, this is a concept that is really quite unique. But this concept of, you got it up there? Simultaneously resecting the liver and the rectal thing done at the same surgery.
Wow.
Now that's a big boy, isn't it?
Yeah.
All right. Well, pull it back down now. That would have been decided way back when that combined modality treatment program was going on, that the anatomy of the two was that the rectal cancer is going to be an easy thing and not a big thing. So the fact that they're doing it in this way, doing the liver first and coming back and doing the rectal cancer a few weeks or months later, tells us that they thought it through, and the liver's the biggest threat, right? I mean, that's, and the
out of the
rectal,
bag.
yeah, and the rectal's still there. So I would say that this pays her husband, right? No, wife, is getting absolutely the highest level of treatment. They've got to have an excellent response to chemo for all of these spots to have gotten smaller, and they are treating your wife with curative intent instead of palliating her progression and death, which would have been the old thing.
Explain what palliating means.
Palliate means make easy. Put a Band-Aid on it and
just make them rest easy.
Make them
So, Bill, in the question, it says in one sentence that the rectal cancer is gone, and next sentence that she's scheduled for rectal surgery. Are they saying, well, we still think there may be some cells
Oh,
there?
yeah, absolutely.
Okay.
Yeah, absolutely. And that's what the liver is, too. If it's small enough where you don't see it light up on PET scan, but that you got to go in there and get everything that was involved at the time of diagnosis and a margin.
So does that mean that if the patient undergoes rectal surgery, did they become a long-term ostomate?
No, there's two ways of doing it. There's what's called a low anterior resection, and they are able to.
So they are doing a resection.
Yes, and they're able to hook that up to the anus.
So they're just taking out the bad part.
Yeah, but if the anatomy is not sufficient to leave you enough anus to do an anastomosis, then yes, you have a permanent bag, and that's not enough information to tell you.
Right.
There.
Okay.
But this is the exact same concept with breast cancer and lumpectomy. Remember, if you give chemotherapy before lumpectomy, if it's big, you still go in there and take out the breast cancer. We've talked about that many times. And if at surgery there's a complete pathological remission in the breast, no active disease, you'll see scarring, and the lymph nodes that were involved before are clean, meaning that the chemo got it all, then you have a much greater chance of long-term survival than if you go in there and say, look, 99.9% of this is gone, but there's still some live cancer cells there. That diminishes your chances of long-term survival.
I got you.
All right.
All right.
So that got rid of that.
What do you got? What do you got for us? Cutting edge. We want to be always cutting edge.
Well, we're going to
COVID talk.
Well, look, first of all, I'm going to pull up the news of the week.
Cool.
I always like the first one on the list this week was the Mediterranean diet can ward off dementia. Now, anything we can do that would ward off dementia, but I didn't buy that one. I don't
buy that. I know quite a few Italians.
Mediterranean, yeah.
And I looked at it.
Yogurt and grapes.
And it wasn't any convention. And then the second thing was when it says...
I better quiet down.
There you go.
John's going to be sending me a company.
I'm getting to COVID here in a minute, but I'm so disappointed in the national media and what they're hyping now. CDC gives guidelines for simulated cruise ship voyages, meaning you dock the cruise ship, you go on the cruise ship, and it don't move anywhere. Now, that makes no sense to me. And then the one says, should COVID shots for teens, instead of going to teens, be sent to underdeveloped nations? I think there's enough COVID vaccine out there between we got billions of doses. The problem's not, should we take it away from Americans and give it to another country, because it's a distribution issue. The other part of that question is, should we immunize teens? And that's a question that I say I'd leave the teens alone for quite a while. I want to see everybody else get immunized first. But I guarantee you, I think it's 16 now is where the age is.
Yeah, it's just went down to
16.
16, and Pfizer may be coming out with 12-year-olds. Their data's just coming in.
The data's fine for 12-year-olds.
Yeah.
I mean, the data works, but I'm not. But shouldn't somebody else get it first?
We still got a lot of higher risk people.
Yeah, let's give them the vaccine first. Leave the 12-year-olds alone. Then the idea about selling the fake vaccination cards and this actually that there is an internet where you can go and you can it comes from China, and you can get a driver's license. You can buy one for $20, but you can buy 5 different states for $40, and they're not a college kid in the country that hadn't got a whole bunch of fake driver's licenses that come from China. And if fake vaccination cards are out there and they're easy to get. I'd say get the shot, don't get the card. Now I want to get into the epidemic a minute. The population of the United States is 332 million, we've had 580,000 deaths, and as you know, our death rate is going down like crazy. Brazil has 213 million, so that means they are 60% the size of the United States, and they've got 416,000 deaths and rising like a rocket. And it's going to be just very soon that Brazil will pass us in deaths, and they're third smaller. India had 480,000 new cases yesterday. They had
What's population?
1.3 billion. But think about this just a minute. 1.3 billion. They had 4,000 documented deaths. That is thought to represent 5 to 8% of the deaths that they actually had, because the way the deaths are counted is by who gets reported to the health department. But if you go, they cremate their remains, right? If you go to the crematoria, or you go over the countryside with a drone, a satellite, or an airplane and photograph the ground, there are cremation fires going on through the entire, out in the boony population of India, where families are burning their dead in numbers that exceed this by a major magnitude.
Since this is India, would it be safe to say that the cause of death is caused by some other comorbidity?
Well, you have no
more
idea.
prevalent?
You have no,
Yes.
we can assume because of the massive amount. That
You assume that people in India are not getting this. Maybe
Well, not only that,
that's
they're not getting autopsy.
No, you got it. You hit the number right on the head. Okay, I'm gonna take it somewhere. Number one, their life expectancy is much lower than ours.
Right.
So let's say our 70 is their 50.
right.
So their elderly may be 45 or 50 years old due to nutrition and whatever. So it is their frail that are dying. It's true in this country that the 20 to 30 age group hospitalization rate has gone up dramatically in the last few weeks. But that was because it was so low in the first place that when the other ones come down, the percentage of admissions goes up even though the numbers don't change.
Right.
So I haven't lost any sleep over that.
Yeah.
But the fact that percentage of people are dying and dying so rapidly is an index that they have. A lot of Indians are fine China. Okay. Now, they are dying with a comorbidity from the COVID. Now, I want to switch this because there is some stuff on the internet that I'm sure you've seen of self-reported complications of the vaccine, where they are reported to this national database, and there are people who say 6,000 people have died after the COVID vaccine in the United States. When I was first in college, and we were discussing, and I was in a pre-med program, and the college boards used to have these true and related, or true and unrelated. Most heart attacks occur in the early part of the day. And in that time, the only cereal that was marketed big was Kellogg's Corn Flakes and Grape Nuts. So most of the people who had heart attacks had Corn Flakes and Grape Nuts.
I know where you're going.
That's exactly where I'm going. And they are true. It's true. They died after had their cornflakes, and it's absolutely damn proof positive they died after they ate cornflakes.
I thought it's because they took their pajamas off.
Yeah, that's right. Okay. But anyway, so this is true, and unrelated. Now, of actual deaths following the COVID vaccination in the world have been 40 to 50 thrombotic cases with the Johnson & Johnson vaccine that was then put on hold.
Thrombotic is bleeding.
No, it's thrombosis in the.
But it's bleeding, isn't it?
No, it's a clot.
It's a blood clot.
Okay.
Blood clot. Okay. That's out of some 160 million, And as I said a couple of weeks ago, the natural history of sagittal sinus thrombosis or deep venous thrombosis per million people would be 70 and not 6. So you could just as easily say Johnson & Johnson is protecting you from the thrombosis. So I'm just trying to say that the press makes Chicken Little and the
Mountains
sky
out of
is
molehills.
falling. Well, not mountains out of molehills, but they look at they look at opposite sides of the data. They look at the data and they don't properly.
Well, if it bleeds, it leads.
Yeah, well, but Ray,
There you go.
We're not going to talk about going back and forth with stuff, but Ray always says, just look at the math. I mean, look at the numbers. Tell me about the math and tell me about the numbers. So that 6,000 people that have died. Oh, and those are all those
That's
people,
all self-reporting.
they're self-reported. Now, a couple of cases yesterday somebody brought to me to look at. My mother was on hospice and died 7 days after the vaccine. I know she died because she was on hospice, but I was instructed by the nursing home that I had to report this, and that's exactly how it says. So to seize on that number when these people are told you must report this because it occurred within that first, 12 days or 15 days. I think the thing for the clot's 15 days. So since that came out, if you get a runny nose, a hemorrhoid, or your husband shoots you within 15 days of taking the COVID vaccine, you're supposed to report it as a complication. I mean,
Well, you're exactly right, Bill, and that's one of the things that's just so bothered me about this whole pandemic reporting business. If you're going to use numbers, you need to use them properly, and almost always you need a numerator and a denominator. Okay, just a number all by itself.
Now, you got to explain that now.
All right, so you got the number on top of the fraction, number on the bottom of the fraction. It tells you the percentage or the ratio of the two.
2 over 4 is a half, right?
Right.
2 over 4 is 1/2?
Yeah.
Okay,
Yeah.
good.
So, and that's tough math there, Bill.
Yeah, that's right.
That's right short of
We had
calculus.
to think twice on that.
All right, so when the FDA said, okay, you got to stop this vaccine, you got to put pause on this thing. That was 6-7 cases and 6-7 million shots. That's 1 in a million. Now, I can tell you that's not something we in medicine worry about as 1 in a million, because you got to look a long time to find 1 case in a million. So, in a lot of our minds, that was way overreacting. But just to throw that out there when you're trying to sell a vaccine and say, well, we're going to stop this vaccine over 1 in a million cases, that's very mixed messaging, because you're trying to tell the public, hey, this vaccine's safe, this is okay. Well, hell, just work it out in the background and figure out what it is. But just to say we're going to pause the vaccine because we had 6-7 cases.
That was not good marketing.
Not good marketing, no. That'd be like having Consumer Reports selling your Cadillac. It's just not going to be good. Anyway, I go mentally, it's the opposite of critical thinking. It's just meant to confuse folks. And we've got enough folks out there that are confused enough. Just this week we had, or 2 weeks ago, we had, well, you can, as a senior with a vaccination, you can be outside without a mask. Well, 3/4 of the country's been outside without a mask for the last year. So for them to come out and say that you officially you can go outside without a mask is really something. Well, then they come right behind that and say little children going to summer camp this summer going to have to wear a mask. Children, Bill and I've said this all along, children don't wear masks.
Exactly.
And if they do, they're packing dirt in their face. I mean,
Exactly.
It's ludicrous. Children are not terribly affected by this virus. It's rarely that they die, but very, very rarely. Rare as hen's teeth. And we're telling them that they're going to mess up their summer, and we're going to have summer camps that got liability issues and going to have special waivers signed and scare parents. So you're going to have to sign that you're not going to sue us out of existence if your child gets COVID. It's nuts.
It truly is.
Well, yesterday, Cobb County, a judge said...
Cobb County, Georgia.
Yeah, Cobb County, Georgia. A judge says the county can make these kids going back to school wear masks next year. And that just makes no sense to me.
It doesn't. And every week what we try to do, not only do they bring good information, but we try to bring you a voice of reason, which which shines through right now.
Well, he's the voice of reason, remember.
Well, you won't find any. You won't
You know,
find.
I'm trying to spread the wealth. Okay.
Georgia cancer specialist
Affiliated
affiliated
with
with
Northside
Northside
Hospital.
Yeah, right.
You won't find any major head of any major pediatric board or subspecialty recommending masks in kids.
Right.
Anywhere.
I know.
Okay. And yet we have our CDC saying got to wear them in summer camp.
This is a
The
serious
CDC
question.
has been politicized. Let's call it
Serious
spade or
question.
shovel.
Has the American Academy of Pediatrics made any
Oh yeah,
statements?
they have, and the American Academy of Pediatric ERs, the American Academy of Pediatrics hospitals, all of them have said this is overdone in kids.
See, I don't. We
Yeah.
don't treat kids, so
Yeah.
I'm not watching that.
Yeah,
So
yeah,
you're
they-
watching that.
Yeah. So let's
about-
talk about one other thing.
What
that I'm
about
sure.
what about pregnant women in masks?
Well, they in mask.
Let's keep those
you know,
CO2 levels
they're
up.
not treating pregnant ladies, any different than any other part of the population. So they've not segmented that out.
Well, I'm
Now,
gonna
they've
tell you
not.
one thing: they're damn symptomatic. Then, if they're wearing a mask and they got that pregnancy, because
Yeah.
they short of breath already.
That's what I'm
All
saying.
right, okay.
Yeah.
Yeah, well, the whole thing.
it's your job to
well,
keep
my
up with
family
all
went
that.
through this because I had a grandchild born during the pandemic, and my daughter and her husband were isolated from the family, and the contact was very different than any grandchild we've ever had, and that other set of quality eyes and caring eyes on the case was pushed aside. And, in medicine, we want to make sure as many people are paying attention as
Right.
possible because that's part of your quality control. You say, well, what about this? Or did you think about this? Or whatever. Families add to not only comfort of the patient, but to making sure something's not being slipped up.
Yep.
And so it's somewhat arrogant in our profession to say, well, we don't need you, and your patient doesn't need you. Well, that's asinine.
That's a live granny cam right there.
Yeah.
When the grandparents can be there in the delivery room and in the nursery,
Yeah.
that's a granny cam first
On
class.
steroids.
Yeah.
So the other thing that came out yesterday was the. I'm trying to remember, Bill. I sent it to you. I don't remember if it's the Preventive Medicine Society or what it is, but there have been 10 million missed screenings in 2000.
Cancer screening.
Cancer screenings in 2020.
That was
10 million. Okay. Now
You talk about your numbers.
you're
That's a
talking about
lot of
That's a
people.
lot of people who we set those protocols up because we know that they reduce death, they reduce morbidity, and they increase the longevity of the population.
And they're
Thrown out.
cost effective. And
Cost
lower the
effective,
overall
less
cost.
expensive.
It's a lot easier to treat somebody for cancer and cure them or detect their heart disease or their diabetes than let them get it and then have to pay the cost of treating the disease with its greater long-term morbidity. So missing a screening test, I don't care whether it's a blood sugar, an A1C, a colonoscopy, or whatever, increases the cost of medical care, even though you got to pay for the PSA or the colonoscopy.
And
that's why they have the guidelines.
The high-end public health people have been saying that for all year, and for some reason our CDC said, well, no, we don't care about that. That don't matter.
So the bottom line is, people, if you have been scheduled for a regular screening, by God, go get it done.
Yeah.
Stay with your PCP.
Mammogram, colonoscopy,
Right.
PSA, A1C, lipids,
Get the
weight
chest
and
pain
blood
looked up.
pressure,
Yep.
weight and blood pressure. When's the last time you went in and got your weight, your blood pressure taken, your blood sugar taken, your lipids taken, and your A1C taken? They talk to you about a mammogram or a colonoscopy.
There you
Well,
go.
the other thing, I don't know if we're running long here, but the other thing
Yeah.
that was said was flu didn't happen this year.
Yeah. Right.
Well, you
What an
don't-
anomaly
yeah.
that is.
Well, if you're not looking for pennies on the ground, you're not going to find any
It
pennies
did
on the
happen.
ground. It did happen.
Exactly, that's
But
the point.
The patients were not in the office, and we were sending people out to the car to test them, and we weren't doing flu tests out in the
doing-
car.
that's right.
So how are you going to find the flu? So that number's meaningless.
Yep.
And so for anybody to say flu didn't happen this year, well, they're just misinformed because we weren't looking for the flu.
Yep. We could do this all day, but we got to get
I
out.
do have
What
to
about
go to
that
work.
tie? I keep looking at your tie. That's a great tie.
What is
Is that
that?
an Irish
Well,
tie?
that is a. Well, it looks like two paddles crossed.
And
And class of '62.
that's a beer mug.
It says 62 on it.
Yes,
That's
it
got to
does.
be a Dartmouth thing.
Yeah, that's my. But,
Oh, that's a-
okay. Animal House. Animal House and beer pong was invented at Dartmouth, and it's a class of 63 writing the writer about the class of 62 at the fraternity.
There you go. I'm glad I brought it up.
And I put this on because they showed Animal House a couple of days ago on the anniversary of, I guess, its production or something, and one of my classmates mentioned it when I was down in.
What a great movie.
All right, I do have a funny today.
Talk to me. Closing up
One of
with a
Bill's
Ray
nurses-
funny.
One of Bill's nurses gave me this one. So, patient came in to see him the other day, and he said, "Well, I got bad news and awful news." Patient said, "Well,
That's
geez,
funny in
geez,
and of
doctor,
itself.
Give me the bad news." And he said, "Well, you're going to die in 3 days." He said, "Well, what's worse than that? What's the awful news?" He said, "Well, I've been trying to reach you for 2."
That's a good
Great
one.
way to get out of here. This segment was brought to you by Georgia Cancer Specialists, affiliated with Northside Hospital. Thank you both. It's always fun. I love trading emails with you guys during the week. Keep the cards and letters coming, and and keep on laughing.
We answered your question from Achilles tendon.
That's right. Emily, thank you for what you do back there. Take us to break, please.
He's sleepy.